Hi everybody, I just wanted to do a little video for you. I have several educational things that we wanted to share with you regarding NG feeds, and then also just some information about when kids are coming up with new G-tubes and stuff like that. So as you guys probably are already aware, I've shared information in the past about our new process for pH testing. You've probably seen these new strips in our med rooms. They are just replacing the pH portion of the gastrocode card. If you still need to check for blood in somebody's sputum or their gastric contents, you would use the gastrocode card, not these. Okay, this is just specifically to check pH when you're going to confirm placement for NGs before feeding or medications. Okay, there is like a little procedure sheet that I made up that lives in the container that holds these cards. Or if you have a question, I did post it on Workplace. I can post this sheet again so that you have it for your review. Basically, you would just withdraw stomach content from the child's NG. You would take out a strip, put a dot of the fluid on each of these little colored marks here. You would immediately wipe that off with paper towel, and then you would hold it up next to your container of strips here and see which it matched best to. If the child's NG is in the correct place, it should measure at a pH of 5 or less, okay? If it's anything greater than that, don't use the tube. It could be in the esophagus, it could be down in a place that it's not in the lung, someplace where it's not supposed to be. So you would want to take that NG out and replace it, or you could, if you don't want to take it out, confirm by chest x-ray or KUB, I'm sorry, to see where the tube is placed. These do have to be checked for quality, just like our AccuCheck strips and stuff like that do, but they have to be checked every 30 days or if you're getting a new lot number out. Now, we are going to be sending these home with families as well. So if you've gotten a kit out for them and put it at their bedside, then when they're getting discharged, this can just go home with them. If they're getting low and you just need to get another set of strips, just get in my office and you can get the strips that are in there. Those have not been QC'd, which is fine, because if they were getting these from Amazon, they would not be QCing them at home either. So those can be sent home with patients from my drawer if you need to have an extra set. Okay, so let me know if you have any questions about that. Hopefully our PUAs are on board with helping us do the QC checks for this. I will try to kind of keep an eye on that as well. And they do, once we've done the QCs, need to get faxed down to lab because they keep track of all that, because these are considered point of care testing for the patients. All right, so next I'm going to move on to a new process that we're actually going to have for our kiddos with NGs. We've done a lot of research and discussion about what's best practice, and as you all know, things continuously change, so we're going to change what we're doing. In an effort to reduce radiation exposure to our kids through multiple chest x-rays or KUBs when these kiddos pull their NGs out and we have to replace them, our hospitalists and PICU docs have decided that we can use what's called a two-method verification for a certain population. If we have kiddos that are coming in their ICU status and they have no gag, they have a neurological deficit or some kind of anatomical issue that would make it that they would not respond appropriately to like a gag or something like that, that would be a population that we would still get a KUB x-ray confirmation of the NG tube. So for the other population that their gag's intact, they're neurologically intact, but they're just having difficulty with feeds, this population we would use that two confirmation verification, and that's going to be when we place the NG, with these, our NGs have little black hash marks on it with numbers associated with it. So once the NG is in the kid's nose, you should be noting where that mark is at the opening of the nair. And so that's going to be your first confirmation of where that number is at. You should not any longer be putting tape on there, because sometimes that tape can get moist and it actually can work itself into the child's nair and can become a choking hazard. So what we would really like you to do now is look at the number, teach the parent to look for the number, and then put a big mark around the tube with a non-toxic marking pen. I believe you can probably use like the surgical marking pens or something like that to make that mark around there. So that will be your first confirmatory method. Is my tube at the same place that it was when I placed it and confirmed it the first time? For this child right now, I'm pretending that the tube is in and it's at the 24 hash mark, and that's where it was when I placed it, and so I'm good to go as far as that's concerned. My next method is going to be aspirating gastric contents. It is no longer evidence-based practice to do the air bolus like we used to do, like us folks that are old. We would, do the air push the air in and auscultate to see if we could hear that whoosh, because that whoosh can actually, especially for the little infants, can be a transferred sound from the esophagus, or actually even if it's placed in the lung. So we are not going to be using that method anymore. So you're going to aspirate gastric content. The only time that we would do a little bit of air in there is if for some reason you can't get gastric content to come back. You can put a small little amount of air in there to try to move the tube away from the gastric wall, and then just try to pull that back out with gastric content again. Then you would use that gastric content. You're going to look at what it looks like. You may see, some pre-digested formula or some digested formula in there. Hopefully you won't see any kind of blood, and hopefully it won't be green. If it's green, that means that you're probably down into the small intestine, and that tube would need to get pulled back a little bit. So after you get your gastric content, you're going to put that on your pH test strip, and you're going to look to see what your pH is. It should be 5 or less. If it is confirmed at 5 or less, then you're good to use your tube, okay? So this will replace the x-ray on some of our kids. You will have to have an order for that. So when our physicians are putting in the order for NG placement or NG feeds, please remind them that in the comments we also need for that to say that we're okay to use pH testing or the two-method confirmation, which could include pH testing and looking at where it is at the nares. The other thing that we're going to be doing is, which we did back in the day when I was a young nurse, was to teach families how to place the NG themselves on their children. So hopefully we will limit the number of times that they are returning to the ER or the physician's office, and then again exposure to x-ray. So the physicians will be determining again the population that is appropriate to be able to have their parents place NGs for them. Again, that population that is neurologically impaired or does not have a gag reflex or has some kind of anatomical issue that would prevent easy placement of the NG. That would not be a population that we would train the parents. So you just have to ask the physicians, are we able to teach the family NG placement for their child? And they should put an order in for that. So this information is all supported through an association of collected experts, and it's called the ASPEN Association, and they trialed all of this and researched all of this and said that this is evidence-based practice. So NICU and our team and the pediatric multi-specialty team got together and decided, we wanted to standardize the education that we're teaching to families, because often when, the NI babies are going home, then they return to the ER, they've had issues, and we're teaching something different than what the NICU taught. Or if the NICU is responding down to replace an NG, they're asking, why aren't you just replacing this? And it confuses our families. So we decided to standardize as much as we can. There will be some small nuances that are different because they have a different population than what we serve. And so things like flushing or checking pH, those things may be a little bit different. So the education that we're providing for families now is going to look a little bit different from what I had in the past. It's going to now be called the NG Road to Home. And ours will say pediatrics and NI's will say NICU on there. So I will be putting together like little file folders, because all the information will not be pertinent for every family. So we'll have to kind of customize what information they're getting. So everybody will get an NG roadmap to home, and then we can just talk to the family about what part of this is going to be appropriate for them. So if they're going to be learning how to place the NG, then we would pull out information for that. If they're going to go home with bolus feeding per gravity with a syringe, then we would pull out information with that. If they're going to go home getting feedings by bolus but on a pump or continuous feedings, then we would pull out information that is pertinent to that. And I'll go through each of these. So the first is this roadmap, and it just kind of talks about the different steps of things that need to happen before the parents were like, okay, they're good to go. Everything's been completed, and the patient is ready to get discharged to home with the NG. So this is the first page. And I'll put copies of these on Workplace as well, so that you can see the actual forms, or feel free to, I'll print up a bunch of them today and put them in my files, because we'll be good to go. The next one is steps to placing an NG tube. So this will be for that patient population that the providers have said, yep, the parents are good, they're trustworthy, the patient has intact gag, they're neurologically responsive. So this would be a good candidate for the parents to go ahead and learn how to place the NG. And we'll talk about those steps in just a minute. If the parent is placing the NG, then there will be a competency list for them to fill out ahead of time. Jen has been gracious enough to purchase brand new little infant mannequins for us that we can actually pass an NG through. You'll see one like this, but I also have another one that you're going to see in a little while that has a trach, a G-tube, and ostomy. So this is a multi-purpose infant. So I'll leave one that's kind of without all those accessories so that we can use this one to use for NG placement, okay? So you'll be using that. So the parent will actually first will demonstrate on the infant how to measure, how to place the tube, and then the parent will practice a couple of times, and then the nurse will fill this out, and it verifies that the parent is where the parent is at from 1 to 5 on their competency of being able to effectively place the NG. Anybody that's going to be taking care of the child at home, using the NG at home, or placing the NG at home, must complete this competency. So, if it's the Nana at home, then they need to come in and they need to have this training completed. Just like when we have kids with trachs and stuff like that, all family members that are going to be caring for the NG or the child, and giving feedings or anything like that through the NG have to be checked off. So then there's a list that talks about, or a guide that talks about steps to feeding with a syringe, and it's just kind of a simple step-by-step guide that would be pulled out and put in their information packet, okay? And then we would review that with the family as we would do kind of a precursor when we're training with the mannequin, and then we will have, as always, the parents do that hands-on education at the bedside and demonstrate several feedings. My goal would be that they actually demonstrate 2 feedings on their child, just like they do now, per caregiver before going home. That would be the optimal goal. I then did make up an education sheet for if they're going to use the feeding pump at home. And basically it's the same as the syringe. Instead of attaching the 60 ml syringe, though, they're gonna connect the feeding bag and set up the pump and stuff like that. So not a whole lot different there. And the same things for administering medication through the NG. So they're all basically the same, very simple to use, step-by-step guides, and that will make up the booklet or the handouts that we're going to get to the family. I do have folders that we purchased that I will punch holes in these, so as you gather that equipment or the forms here, if you could just grab a folder also and put them together nice and neat in a folder for the family, that would be great, so it keeps all their paperwork together, and then we will send that home with them. So the next step that I want to talk to you about, just so that everybody is educating the exact same, is that most of the time we're going to use this footprint type of an NG for our patients. Now, if it's an older kid, which we have had in the past, you would just use a 10 French core flow for them. Because obviously these aren't going to be long enough for them. The goal is to really have the smallest tube that is the most flexible. This is a silicone feeding tube, and so it's nice and soft. It's soft on the nasal mucosa, doesn't hopefully cause breakdown, and can indwell. The manufacturer says that this can indwell for a 30-day period of time. And that is going to be a difference that we have between us and NICU. They are only going to have theirs indwell for 2 weeks, but we have said we can go by the manufacturer guideline, and that's 30 days. So you're going to, the parent would gather all the supplies. That would be the tube, the syringe to check gastric content, and then pH test strip with the little container so that you can verify where your pH is at. And then of course your whatever you're going to use to adhere the tube to the face. So you guys, I think I've got almost everybody trained for my little bag to go supplies here. And I like to send home some thin duoderms with them, and then tegaderms, tape, and then a little bit of Mastisol. So I'm not going to use the Mastisol on the mannequin, and I won't have the parent actually put a dressing on the mannequin because it will break the mannequin down over time and make it sticky. So we won't actually do the dressing on the mannequin. But you can talk to the family about how to do the dressing. So just have them get all their supplies together, because we want them to mimic what they're actually going to be doing at home, because that will give them good practice and an understanding of everything that needs to happen while they're at home. So, you know, just like all of our infants, we can either swaddle or do, you know, have, I always tell them this is a 2-person job anytime that you're doing stuff with inserting the NG or changing out the dressing. 2-person job, 1 to hold and 1 to do the procedure. So we take our NG out, and as all of you guys know, that you're going to take the tip of the NG to the side of the, right at the side of the ear, and you're going to go to the earlobe. And then you're going to go down and go midway between the xiphoid process and the umbilicus. This is, the mnemonic for this is called NEMU, okay? So it's midway between the xiphoid process and the umbilicus. So nose to ear to midway between the umbilicus and xiphoid process. And then you're going to mark that. For this baby, actually is a 22, okay? Now when so you're gonna, you know, tell the parent, you can write it down on their little sheet, marked at 22, and then make your mark around with a non-toxic permanent marker, all right? Then for this mannequin, they give you these little squirt bottles, and it has to be filled with sterile water, not saline, sterile water, okay? And then you have to pre-lubricate the nostrils with this saline, and that makes it slippery because otherwise you're trying to push plastic against plastic. And then go ahead and show the parent how to insert the NG. And this 8 French should fit. It's per specification. So this is the first time I've been using this mannequin, so it's a little tight. So if it's a little tight, just try to lubricate again, or you might have to go to the other side, I'm not sure. When you're training the family, tell them if the child leaves the tube in for 30 days and you're going to put it into the other side, or to take the tube out and change it, they need to switch nairs, which I'm sure everybody knows that, but this helps to prevent breakdown of the mucosa in the nares and also skin breakdown on the cheek. And this infant is, well, I'll have to work with these infants a little bit and make kind of root their nostrils out so that the tube will go down easily for the family. Anyway, so once you get this in and the family has practiced this, and you feel like they've got the concepts down well, then just have them walk through how they're going to secure it. You know, they would use the Mastisol, let it dry, put the Duoderm down. I always put a little bit more Mastisol on there because it makes the whole thing sticky again, and you got to wait for it to dry to make it sticky. And then you can put the Tegaderm down. Or just put one piece of tape down for now, and then have them check their gastric content by withdrawing, and then checking their pH. If it's 5 or less, then they can finish securing the tube, and then they're good to go. So just have them practice this measuring and insertion, and then doing their steps for checking placement a couple of times so that they feel comfortable. And then just give them kind of guidance along the way, some tips. And, you know, when they go, then they should place it on their own child. So, you know, one time before they're getting ready to go, my theory is always to make sure that you're trying to put that NG in fresh right before they go. Because if it's a kid that they can actually keep it in there for a while and the child doesn't pull it out, it's good for 30 days and you've got a brand new tube in there, and then they're good to go for a little while. So when they're doing the dressing change at home, just like here, when we've got a kiddo that we need to totally change out the dressing, we have a helper come. So one person is going to hold and swaddle and hold that tube while the other person undresses. Okay, so that's what I teach them. And then, you know, you clean the face, look for skin breakdown. If there's any kind of skin breakdown, they should go ahead, if they've been trained to change the tube, change that tube out and go to the other side, and then let the provider know that there is some skin breakdown there. So that's kind of our new thing. So for not all kids are going to get x-rays anymore. So you just have to check with the provider. Is this a kid that you want us to get an x-ray on, or are you good with the 2-method verification of NG placement? And then would this be a kid that you want us to train the parents to place the NG, or are they, you know, have some extenuating circumstances that they would just return like always to the ER or to the provider to have the NG replaced? The other thing that we have started recently, and some of you have already had experience with this, is that all kids that are going home with NG feeds are going to have a referral to Dr. Zadie's office, because he'll be the troubleshooter if they're having problems with the NG, if they need different supplies, and then if there's a prolonged period of time that they've had the NG, then Dr. Zadie will have that crucial conversation with them about transitioning over to a G tube. So they also have a dietitian there in their office. Her name is Vicki, and she helps with increasing or feedings or changing the types of feedings if the child continues to have difficulty with gaining weight or tolerating the feedings. So just wanted to let you guys know that important piece of information. Okay, so the next thing that I'm going to talk to you quickly about is that I have developed I found that information for kiddos that are having PEG tubes placed or new G tubes put in was lacking. And so I developed an educational booklet that I have shared with the Pediatric Multi-Specialty Clinic. I have shared with the gals down in PACU, or not PACU, but OSC, and yeah, it's OSC now. So that they can give these to families that are coming in that are getting PEG tubes. So I have them in the drawer of my office. Please, if you want to take the opportunity to look at what's in there, it has a lot of great information. There are pages in here that if you have a kid that's got a newly placed PEG in, that should be filled out. There's a place that we can write in the size, the French of the PEG tube, and then kind of specifics about feedings and stuff like that. So, and it gives step-by-step guidelines of how to actually clean the tube. So kids that are getting the long PEG tube put in, and I'm gonna, sorry, pop out of the video for a second and come back. This one has a balloon in it that gets blown up. Most that are getting put in will have a mushroom-like little disc in it called a bolster, and that's what holds it in. These have to stay in for 3 months to develop that tract or a stoma hole there, and they also it brings the stomach up to the abdominal wall, and then it attaches there. So that tract gets fully formed over a 90-day period of time. After that period, conversation can be had if the child continues to need it, that they would change to a low profile tube. Important things that you need to know about this is that when the kiddo's coming back up, they have a gauze there, and that's okay. It should get changed out though if there's a lot of discharge on it, because keeping a moist gauze up against warm skin is a recipe for bacterial growth, and then you can get into a lot of cellulitis and problems, infection in that newly forming stoma. So make sure you keep that clean and dry. I always tell parents after the first day of surgery, if there's no drainage there, take it off and leave it off. Don't put anything in between this bumper and the stoma site itself, because again, if it gets moist, it can trap bacteria, and then you can have all kinds of problems there. So routinely, unless they have skin sensitivity or drainage there, they should have nothing in between this bumper and the skin. So I begin teaching, I don't teach the day of surgery because that site's pretty sensitive. Everybody's worn out, the child's worn out, the parents worn out, and they're really not super receptive to a whole lot of education. And so we just start teaching the basics as far as feedings and starting to get them used to seeing the tube. Usually the next day, Dr. Zadie comes in and he talks with the family, and he talks about rotating the tube. And I just can't get this big tube into this baby right this second. But so he's got the tube in, and he talks to them about cleaning well underneath. And you can lift this up. This is called a stabilizer bar, and that's there because they don't want the tube pulling on the stoma site and creating granulation tissue or breakdown. Okay, so this is the stabilizer bar, and it should be flat up against the skin, but not snug. You should be able to really fit a dime under there. Otherwise, it's too snug, and you need to loosen it up. And this does move. It just kind of slides up and down the tube. See how I can slide it up and down? So once, first I teach them clean there. You should clean twice a day with just like a sterile water, or I'll send home some saline bullets with them, and then just with Q-tips there. And start at the 12 and work down to the 6 clockwise. Get a new Q-tip and go from 12 counterclockwise to 6, and do that a couple times till you get all the crusties off. And then they should do that with dry Q-tips so that it's nice and dry afterwards. Once they've cleaned, then they're going to take this stabilizer bar and the tube itself and just do a little twist around. And it's going to have a little resistance at first, but as that stoma heals, it will get easier to do. And the reason that they do that is so that skin does not adhere to that tube, and it lessens the chance of granulation tissue and stuff like that adhering to it. So it is important that they rotate that tube once a day. So initially clean twice a day, turn the tube once a day. Once that site is clear and it's not draining anymore, they can really go to once a day cleaning on it as long as it looks nice and clean and dry. And then I teach them about looking for signs and symptoms of infection, which is redness, drainage, tenderness, running a fever, any kind of swelling around that site. If any of those things are happening, they need to call the provider right away to be seen, because they could have some kind of a cellulitis or stomal infection going on. This is a tube that does not get changed out by the parent. It is changed by the physician, either converted into a low profile or just removed totally because the child is now adequately able to take nutrition by mouth. So let me know if you have any questions about that. The last thing that I want to talk to you about is when the kids come up, sometimes if they're having to have that long-term gastrostomy tube in place, then they will convert to this low profile button. And you may see two different types is what Dr. Zadie says that he uses, and one is the Mickey, the other is the AMT Mini. Now, if they have to have a GJ, then that you'll see an additional kind that has several different ports on it. The big thing about this is that the parents, if they've had the PEG, they're used to kind of working with the feeding tube. They know some specifics, they know about cleaning, but just reinforce they've got to, again, clean this once a day. They should also rotate this. But this is something that they also need to use. They have a syringe that comes in their kit that is a slip tip, and it fits nice and easy into the side of this balloon. And they should check the amount of water that is in this balloon on a weekly basis. And in their kit, depending on the size of the tube that they have, it's either going to be 3 to 5 mLs of water, okay? So either if they've come here and they've had a place and they're on the floor and they're getting discharged to home, we'll order those extra things for home from them. They should have an extra backup emergency kit ordered for them, and sterile water with adapters so that they can withdraw the water out of there. So if they need to add water to the balloon, they can. Just tell them that if they're constantly having to add water to the balloon, they need to call Dr. Zadie's office or whoever placed the Mickey and have that changed out. They will have this changed out the first time in the office, and they will instruct them on how to do that. I do provide education for that in this manual, but Dr. Zadie, if he's the one that's converted them, doesn't want to do that first change in the office with the family, so that way if they have questions or they don't get stuck at home and they're changing it and they can't get it back in. So that's something that they will practice at in the office, I believe. Okay, so that's all I have for you right now. I know that's a lot of information. If you have questions, please feel free to reach out to me. We are going to post this on Workplace, and I will have all of the paperwork also placed there so that you can reference it, but you can always get in the bottom drawer of my filing cabinet and pull stuff out and look through it if you have questions. So thank you for watching. Have a great day. Bye.